Okay, hello everyone. It's officially noon and we're going to get started. Thank you for joining us on this Project ECHO COVID-19 session during this unprecedented and challenging time. My name is Petros Levounis. I'm a professor and chair of the Department of Psychiatry at Rutgers, New Jersey Medical School here in Newark, New Jersey. I will be facilitating this afternoon's discussion. For anyone new to Project ECHO, the rapidly changing situation with COVID-19 necessitates a responsive, fluid, and interactive communication strategy. Project ECHO fosters partnerships between experts and frontline healthcare providers. It is based in education, begins with information, and extends to better outcomes. Today's session was specifically devised for frontline providers in outpatient settings. For anyone who's familiar with the Rutgers Project ECHO telemedicine clinic offerings, due to shifting priorities, we have changed our previously scheduled topics in order to focus on resources for our response to COVID-19. The purpose for today's session will be provided to be on COVID-19 and mental health. We appreciate all of the questions you submitted upon registration. We're sensitive to the urgency of your request, and we're going to make an attempt to answer as many of the questions on this call. We've had over 1,200 questions submitted. The Q&A feature is also where you will be able to ask questions during the session, which will be compiled and presented to the speakers after the presentations. There will be a significant amount of time devoted to questions and answers at the end of this session. Thank you very much for your participation. I hope we can have a rich discussion and ensure your patient care questions are answered during our time together. To introduce you to our technology today, if you have not already registered, we ask that you register using the link in the chat. This session is being recorded and will be distributed and posted on the Rutgers Project ECHO website after the session, including any links and resources shared during the presentation. Finally, as the timeliness of this content changes with each passing day, if you are viewing this recording at a later time, realize that this may not be the most current information at the time you are viewing it. Note that information and websites for the New Jersey Department of Health, the CDC, and covid19.nj.gov as resources for healthcare providers are provided on the New Jersey Project ECHO COVID-19 webpage. Okay, so before starting, I also would like to thank very much our guest speakers today, who are Ms. Nancy Costello-Miller and Mr. Craig Sashihara from the state, and who will be joining us in a little bit. Also, I want to introduce the two panelists who are going to be with us throughout this mental health and COVID-19 sequence. Dr. Rashi Agrawal, who's Associate Professor and the Director of the Residency Training Program in Psychiatry at Rutgers, New Jersey Medical School. And also from our own school, Mr. Clement Chen, who is a pharmacist and also going to be doing the presentation next week. He works with the Center of Excellence in Addictions for Northern New Jersey. All right, so let me share my screen here. And I think I know how to do this. There we go. And this is here. So I'm going to be the presenter today for the didactic portion of this session. And as we may have mentioned before, we're going to have 4 sessions. Today, we're going to be focusing on general mental health. Next Friday, Clement's going to be talking about addiction treatment and COVID-19. And then on May 1st, Rashi Agrawal is going to talk about healthcare workers. And finally, on May 8th, we're going to have an open discussion about rebuilding in the post-pandemic world. And Dr. Frank Inassi is going to be joining us for that session. All right. The few minutes we have today, the way I would like us to conceptualize and organize our work in mental health in the COVID-19 reality is in 3 major parts. First, what do we do with patients who already suffer from psychiatric disorders? Are there any unique aspects of COVID-19 that we need to consider in working with patients who are already diagnosed with psychiatric illness? The second part is addressing patients who may not have had a psychiatric disorder and now with the stress of COVID-19 may be emerging with a new psychiatric disorder. And then finally, I want to spend some time addressing the mental health needs of the general public, the people who may not meet criteria for a formal psychiatric diagnosis, but also suffer from psychological stress and what we can do for the general public. We're going to close with a couple of ideas about new directions and where we go from here. Okay, let's start with working with existing psychiatric disorders. And we're going to break that to the psychotic and the non-psychotic disorders. For patients who suffer from severe mental illness, who may have schizophrenia or severe bipolar disorder, some of the unique aspects have to do with the cognitive deficits that come along with severe mental illness. We have all these directives about washing hands and social distancing, and these may not be all that easily registered and remembered for our patients with severe mental illness. So a repetition, non-frustration with patients who may not get it the first time around is certainly in order. Second unique aspect with patients who suffer from severe mental illness has to do with injectable medications. A lot of the antipsychotics come in injectable form, and with social distancing, we have moved, of course, all our outpatient services to telepsychiatry, to telemedicine, but patients still need to come in to get their injections once every 2 weeks or once a month. What we do here is sometimes we switch the injectable medication to oral medications once a day, or what we do in our building right here is we have one floor still open primarily to help patients who need to get their injections. Now, while all of mental illness may get, many parts of mental illness may get worse with trauma, with the pandemic like COVID-19, the issue of stigma is particularly dear to our hearts. Patients who take psychotropic medications may have side effects. They may feel drowsy. They fall on maybe on a table or in the bus or in the train, and then people find them even more troublesome, and they may stigmatize against them even more severely. Patients who take antipsychotics having involuntary movements, patients on clozapine may have some drooling, which in this particular context of COVID-19 makes them even more of a target for stigma and discrimination. There are some good signs here in that for a lot of our patients with psychotic disorders, the evil world and the evil government are finally materializing, and they have been right all along. So the whole paranoid stance has found some more meaning for them, and that actually may be more organizing and more pleasing to them. Also, the issue of social isolation. Most of us think of social isolation as a terrible thing, but if you suffer from significant negative symptoms of schizophrenia, and your worst nightmare is going to family dinners and having to socialize with people, this situation now where we're all in the same boat may be not all that bad, actually. And we do see this with our patients. When it comes to depression, and more specifically about suicide, there are several stressors that make things worse. Economic difficulties, social isolation is particularly hurtful to patients who suffer from depression and may have a propensity for suicide. Access to mental health treatments is much more limited. We do support and we do work with telemedicine and telepsychiatry, but this actually is not the same as having easy access to a person who's going to be treating you. There's a lot of guilt associated with depression. Why me? Why not somebody else? Am I going to be infecting my loved ones? Am I going to be infecting my children? And if you are in this predisposed to this kind of guilt thinking, then COVID-19 will make things worse. Also, statistically speaking, we do see an increase in suicidality in late spring and early summer, which is exactly the time of the peak now of COVID-19. So we're bracing ourselves for the possibility of increased suicidality in late April and May. On the good side, there are significant data, significant research to show that people who do have a propensity to suicide get a pulling together effect, some kind of we're all in this together, that actually may decrease suicidality. So yes, some stressors, but also a pulling together effect. All right, moving on to working with emerging psychiatric disorders. One way to conceptualize this is through PTSD. Carol North and colleagues from Washington University in St. Louis first said that when it comes to traumatic events, you really should start your assessment with whether the patient suffers from PTSD or not. And then once you have established that, then you can look for other psychiatric disorders or maybe some other subdiagnostic distress. So as you can see in this slide here, you end up with 4 possibilities: having PTSD with other disorders, just PTSD alone, some other psychiatric disorder, or just suffer from what Carol North described as subdiagnostic distress. As it turns out, even for people who have been directly and very severely exposed to traumatic events, the subdiagnostic distress is more than 50% of the entire population. The majority of people, much to our surprise, even though they may have been exposed to extreme and really severe traumatic events, may very well end up in the subdiagnostic distress category. Okay, PTSD is in general about 8% of the population will suffer, have a lifetime prevalence of 8%, about 10% for women, 5% for men. It ends up being about 7.5–8% for the general population. But there's some interesting thing that happens with PTSD. This is a study, an older study, that shows the chance, the risk of PTSD following different traumatic events. And as you see here, kidnapping and torture and captivity are the highest. And if you happen to have been exposed to this kind of terrible situation, you may have more than 50% chance of developing PTSD. But the rates keep on coming down. And as you see on the very right of this diagram here, natural disasters result only in about 4% of PTSD. And of course, a pandemic like COVID-19 will go along with a natural disaster. There's not a human agent behind it. And perhaps that idea that there's not somebody who's responsible for the trauma, like in rape or in terrorism or shootings, that perhaps may result in a lower rate of PTSD. I'm not going to go into great detail about how to diagnose PTSD with the DSM-5. As you very well know, there are 5 criteria for PTSD. You have to be exposed to a life-threatening event, and then there are the flashbacks and the intrusive re-experiencing of the event, the avoidance of anything that may remind you of the event itself, then a sense of numbing and having negative thoughts and feeling, before finally getting to the final cluster of symptoms of PTSD, which is a general hyperarousal, a general anxiety that seems to have been raised throughout the person's life, more of a generalized hyperarousal condition. As it turns out, criterion C and D, the clusters of C and D, the avoidance and numbing, the negative thoughts and feelings are most predictive for the severe form of the illness. People who suffer from prominent avoidance and numbing symptoms are the ones who most likely are going to suffer from the most severe form of PTSD. And finally, this also comes from Carol North's work. I've worked very closely with her after 9/11, and we came up with this intervention roadmap, which reflects the assessment roadmap, essentially going through diagnosing PTSD, diagnosing something else, and then if the patient suffers from PTSD or some other psychiatric diagnosis, then we go to a more formal treatment with medications and psychotherapy. But if the patient falls in this subdiagnostic distress that Carol North coined, then education, reassurance, some of these interventions is what we should be using. At the end of this presentation, I have a psychological first aid kit. I don't know if we're going to have time to go over it. If we do, then this is what we're talking about in terms of education and reassurance. All right, finally, addressing the mental health needs of the general public. This is a general diagram, a profile of what happens psychologically in the general public after a disaster. It's a wonderful diagram in that it does show that at first there may be a heroic moment where people are bunching together, and maybe we're even going through this heroic time ourselves now, where all the resources are put together, and maybe even from a general psychological state, we may enjoy a honeymoon period before we get into the disillusionment phase when we have to live with the consequences of the disaster, the financial consequences, the human toll, the consequences of the isolation, and then we end up reconstructive with reconstruction and rebuilding. The general profile of the psychological state of the community at large following a disaster. More specifically, what data, what research has identified as major mental health consequences of disasters. We have increase in anxiety, depression, some substance use, although I have to say for substance use, we don't have as many new cases. We'll have exacerbation of existing substance use. We certainly have relapse for people who may have been doing well for a while and may have been abstinent for a while. But surprisingly, we don't see as much new onset substance use because of the disaster, of the traumatic event. Of course, we see loneliness, particularly connected to the social isolation of COVID-19, and there is the potential for worsening domestic violence and child abuse. We don't have evidence of that at this point, but there may very well be some increase in terms of violence and abuse. So what do we do? What are some of the solutions that are being proposed? Of course, the digital technologies. Seeing your physician, your mental health provider, your psychiatrist, your support system during these tough times through telemedicine and telehealth is certainly where all of us have been turning. But also the social media, anywhere from Facebook and Instagram, and I don't know, my husband is particularly keen on Marco Polo, another social media kind of platform that have exploded over the past 3-4 weeks and have been keeping people connected. Now, the issue of routines, it's going to come back again in the psychological first aid kit that I may be presenting at the end, but safeguarding our routines, establishing new routines, developing new routines seem to be particularly helpful in times of increased anxiety and depression. Also, recruiting non-traditional groups for psychological first aid. What does that mean? Very practically, we graduated our medical students on Monday, essentially a month before they were supposed to be graduating. And that was a non-traditional way of using our medical students to help with the pandemic that we're living in today. Yesterday, the Army came to our inpatient unit and we had behavioral techs, but they were not used as much as behavioral health techs. They were used more to talk to patients and to organize smaller groups, because that was, of course, much easier to do and much safer to use a group of 2 or 3 people instead of the larger groups that we had in our inpatient unit. So thinking outside the box, using non-traditional people for maybe mental health purposes could very well help us here. Finally, a word about social distancing versus safe spaces. I mentioned before domestic violence and child abuse. We need to still be able to offer some safe places for people who have been exposed to domestic violence. And of course, that has to be balanced against the directives of social distancing. A tough one, but certainly something for us to think about. All right, something more specific about quarantine stressors. We're all under quarantine now, and there are research data that have shown that there are some specifics of what makes quarantine worse. Longer quarantine duration, and even more specifically, an unknown end point for the quarantine seems to be particularly stressful. We are right now in a non-ending quarantine as a society, so that can be very stressful for us. Inadequate information, inadequate supplies, and of course, the pervasive fear, frustration, and boredom that social distancing and quarantine bestows on people. And then, of course, we shouldn't forget about what's going to happen after the quarantine is over. Financial loss and stigma for the patient, for the people who may have been ill with COVID-19. Things to keep in mind for the time after the quarantine ends. So what do we do here? Some of the solutions to these stressors. Of course, try to keep the quarantine as short as possible, always with an eye on safety first. So for safety first, but within that, we'll try to keep the quarantine as short as possible. Give as much information to people as we can. We've seen several governors and several politicians do that very successfully, others not so much. But if you have that ability to give some information, just try to give it as liberally as possible. Provide adequate supplies, reduce the boredom, gaming, internet gaming. I'm not sure what's going to happen to the internet gaming addiction. Our group here studies internet gaming and is particularly keen on internet gaming addiction. But at this point, it seems like it's particularly good for reducing boredom. Altruism. Altruism is better than compulsion, coming straight out of research of quarantine situations. So mandating people to wear masks may be one way to go, but also speaking to their altruism and saying that this is how you can help the elderly, this is how you can help your fellow human beings, may actually get you farther than mandating this and mandating that. All right, so just one more word about new directions from here. The whole issue of resilience seems to be reconceptualized, and we've had the individual resources. We've been seeing this throughout this presentation, the individual and the community resources, what the person can do to make things better, what the community can do for the person, how can the person recruit the resource of the community so that she or he can protect herself or himself better against the disaster. But what's fascinating here is the final one, an existential concept. Who do I want to be when this is over? And these existential resilient resources are somewhat new to the study of resilience. To me, it brings back echoes from World War II and Winston Churchill when he said about this will be their finest moment. That was particularly helpful to the Brits back then. I heard Queen Elizabeth II's speech the other day. It really had echoes of a similar idea of who do we want to be, how do we want to view ourselves, how do we want other people to view us when this whole thing is over. All right, and with this I want to thank you. As I mentioned before, before going to the psychological first aid kit, some resources. There are so many resources around. There are just so many emails. There are just so many websites. So for this part of the mental health and COVID-19, I would go to psychiatry.org, which is the website for the American Psychiatric Association. Pretty much everything is well organized and can take you to all kinds of other websites. And the Center for the Study of Traumatic Stress also has a wonderful website and a lot of resources. So instead of giving you dozens of those websites, I decided to just give you two. And again, the psychiatry.org, the American Psychiatric Association website, does have, is a portal to pretty much everything else you will need. Okay, the appendix here are the psychological first aid, and we'll go over it if we need to. But if we have some time, I mean. Let me just stop here and invite Nancy Costello-Miller to give us her presentation.
Hi, good afternoon, everybody. We have a couple of slides, I think, that we'll put up, but essentially, this is a few slides. The New Jersey Division of Consumer Affairs regulates several professions and occupations through their various professional and occupational board. The division has created a really good website connection for the COVID-19 information and documents and things that you can equally find very, very quickly. That particular link that you're seeing now on your screen are frequently asked questions with regard to telehealth. So, okay, just that's a good source for you to have. The professional boards that certify mental health practitioners or license them include the 5 that you see: psychological examiners, both licensees, and they also have permit holders. The Board of Social Work Examiners with licensed clinical social workers and licensed social workers. Certified social workers cannot provide clinical services. Board of Marriage and Family Therapies Examiners has marriage and family therapists, as well as the professional counselors and alcohol and drug counselor committees under the Board of Marriage and Family Therapy Examiners. I just note that there are some practitioners who obviously can practice independently, those with full clinical licenses. Others have authority to practice, but those are under the supervision of someone else. Okay, next, please. The next 2 slides basically refer to the statute and show you what the definition of telehealth and telemedicine is. That statute was enacted back in 2017. Some of the boards have already, I think the medical board has put out its regulations on telehealth or telemedicine, but the other agencies are in the process of getting those out, and those regs are designed to help practitioners under those licensing bodies have best practices and to prevent fraud and abuse and the way that goes. Okay. And again, telemedicine, that's essentially the definition. Now, one of the things that we've noticed is that everyone is anxious to permit the use of telehealth and telemedicine when they are having to deal with this particular crisis. The Department of Health and Human Services, as well, and its Office of Civil Rights, have permitted or relaxed, if you will, some of the technologies which would normally be non-HIPAA compliant to be able to provide these services. So as you see on the bottom, those communication tools that would be permitted during this state of emergency would be platforms such as Zoom, Skype, FaceTime, Google Hangouts, and so on, but not public-facing technology. So TikTok or Facebook Live would still be not able to be used in any type of provision of mental health services. Next. Again, whether you're providing services in person or remotely, the standard of care has to be met. And although the Office of Civil Rights has given its notification to have enforcement discretion, disclosure, unauthorized disclosure of client information could still be a problem, and HIPAA rules do still apply. Again, it's just a relaxation of the HIPAA technology limitations. Next. Excuse me. You want to obtain consent, obviously, as you did, and having the identity, knowing the person on the other side is really the person who you think it is helpful. You should describe who you are when you're providing those telehealth services, and all of these things should be documented in the client record, okay? One of the things that the legislature and the governor have done is to provide an accelerated temporary license program in the state of New Jersey for the duration. Those licenses permit people who are out of state applying for the specific corresponding license or certification in New Jersey have to be in good standing. And if so, you could be granted a license for as long as for 180 days, subject to another extension. And the division has waived certain requirements, including fees for those licenses. Okay. There is a permissible, even with absent that sort of hurry up and get a quick New Jersey license for the state of the emergency. If a student, for instance, were in a school in another state and that student is now back home in New Jersey, but had a particular relationship with a healthcare provider, let's say in Massachusetts, for the purposes of the emergency, that Massachusetts practitioner would be permitted to continue treatment for that New Jersey person, even though not New Jersey licensed, which would normally be a requirement under the telehealth laws. Okay. Good, that was good. So just essentially, there's some really interesting things that people are going to be talking about here, but essentially practicing remotely requires you still to maintain the standard of care. You generally need to be licensed. You have to have consent. The obligation to keep client records still exists, medical or client records still exists, and you need to be able to do that to the best extent possible. There's additional information that you can find, as I said, not only on the Division of Consumer Affairs website, but for certain other mental health practitioners, the SAMHSA website also has some guidance that's helpful. And I believe, Doctor, it actually refers to the American Psychiatric Association's website as well. So a lot of good information out there. I would also say if you have specific questions about how you can be providing these services during this time period, the Division of Consumer Affairs has a link on its website to ask Consumer Affairs. You can email a question in, and those questions are being routed to the right people so that one hopes you're able to get an answer pretty quickly. Okay, thank you.
All right. So I am going to go back to this. So let's have the questions now. Let me see. Rachel, you want to bring up the questions? I see that we already have some questions here.
Sure. So in the Q&A, it looks like there's about 9 questions. The first one is...
Oh, I see.
Okay.
I got it.
Okay.
I had to get out of my screen. Very good. So let me just read the questions and then see how together we can answer them best. Is there a safety net for a person who do not have a current prescriber due to practitioner's retirement, but have been stable due to medication regimen? Okay. Is there a safety net for a person who do not have a current prescriber, but have been stable due to medical regimen? We get referrals all the time, and the same way that we would refer somebody to a practitioner in somebody's office, we refer patients to our telehealth system here. I don't see very much of a difference there. Rashid?
Yeah, in addition, like depending on your location, you can also just have your patient or yourself call this number. It's for New Jersey Mental Health Care's website. It's 866-202-HELP. And they, based on the location and other needs, can maybe provide referrals.
Can
That
you
might be
say the number again, Rashi?
It is 866-202-4357.
Perfect. Okay. Great. So despite the increase purchasing in alcohol during social isolation, there isn't an increase in use or abuse. Okay, let me just elaborate. Next week we have our substance use session, but it's a question quite dear to my heart. We don't really know why, but it does seem that following acute distress, following acute events, people relapse, people who are already having an alcohol problem start perhaps drinking more, but we don't see as much new onset alcoholism, full-blown alcohol use disorder of the severe kind. Now, this is not the same as having a prolonged traumatic event. So this pandemic is not quite a 9/11 situation. It's not exactly like a terrorist attack that happens and it's a very acute event. So we've been in this social isolation and the social distancing for several weeks. So I'm not sure if we are going to be seeing an increase in true alcoholism, in true alcohol use disorders, because the traumatic event is just so prolonged. There have been some wonderful studies that compare elderly men who have lost their wives to either an accident or to a chronic disease like cancer. The ones who have lost their wife over a prolonged period of time are much more vulnerable to develop new onset alcoholism than the people who, let's say, lost their wife into a traumatic but really abrupt event. Not sure exactly why that is so, but it's a wait and see situation. I'm not sure where it's going to end up with the COVID-19 pandemic. Could you please repeat what you said about altruism? I lost audio at that point. Thank you. I'm just saying that from a public health perspective, very often states and the local authorities and the federal government mandate people to do X, Y, and Z. And that, of course, may very well be needed, but recruiting people's altruism, focusing on wearing masks so that people can protect their fellow human beings and the elderly may also be a very good idea. So speak to people's altruism and mobilize that side of people's more mature defense mechanisms may be quite helpful.
First, if I can jump in, this is something we'll be talking a lot more on when we talk about how to take care of ourselves and our colleagues. And it is really about connecting to the meaning we all have in life. So when we're helping others, we feel better about ourselves, and it's much easier to take actions that normally you might not want to like social isolation.
Great, absolutely. Thoughts on ketamine with respect to anxiety, depression, OCD. Ketamine is also currently being used in ICUs to avoid initiating ventilatory support for COVID-19 patients because of its bronchodilator effects. Okay, we do have significant evidence for the antidepressant effects of ketamine, and we do know that it does have a quick onset of action, which is wonderful. But the dosing and the route of administration and the whole context of giving ketamine for the treatment of depression is very different, certainly from recreational ketamine, which is what a lot of patients who suffer from addiction may be using, which I bet is quite different in the context of the bronchodilator effects that we may have in an ICU setting. So it may be a side benefit of getting some antidepressant anxiolytic effect during those times, but I wouldn't really, if a patient really suffers from depression and needs antidepressant treatment, I wouldn't rely on the few doses of ketamine that they may be getting in an ICU setting to treat their depression. Okay, what can parents do to help their adolescents struggling with depression and suicidal ideation during COVID-19? Rashi, you want to take that one?
This is a tricky one, honestly, because teens is the hardest group to connect with normally, with or without COVID. And now if they have enforced lockdown with their parents, which is not always the most pleasant, but in some ways the tips would be the same as the tips we would give at any other time, which is with teens, sometimes indirect support and questioning and presence is better than direct questioning. So, you know, if I ask my daughter what's going on, the answer would probably be no, nothing, right? So it's really being with them in a meaningful way, having a social structure that helps them, being there when they do start to open and talk and really listen in between the lines. And those are the simple tricks in some ways, but if you're really concerned, or if a parent talking to you is really concerned that the kid might actually have serious depression or be having suicidal thoughts because of this negative impact of COVID, I would really strongly recommend calling a helpline or reaching out to a professional.
Absolutely. The other thing to remember about adolescence is that it primarily who the adolescent has the best relationship with that may be the avenue for getting some help in terms of their depression and suicidal ideation. Yes, we may very well have wanted them to see a psychologist or a psychiatrist, a mental health professional, but if the adolescent seems to have a fairly good relationship with their NP, with their general pediatrician, this would be the person to talk to and make sure that they're involved, and maybe that would be an avenue for the adolescent to get some help.
You know, the one other thing that is sort of specific to the current time is that we talk a lot about screen time control normally or usually, but this is the only way to for anyone, not just the teens, to connect with others right now, to be on the screens, and sort of encouraging actual meaningful communication for your teens is also a great idea.
Yeah. I mentioned before that our team here works a lot with the technological addictions, and I have no idea how we'll be assessing or diagnosing patients with technological addictions, social media, and the like, gaming, after all this is done, because of course everybody's using them so extensively. But what specifically would you recommend with respect to consent for telehealth services? And I'm going to ask Nancy to answer that one.
Okay, that's not fair. It's a fair question. The consent, normally there has to be a provider-patient relationship in existence, and there's a requirement to look at medical records ahead of time. For the purposes of the emergency, that looking at the medical records ahead of time has been waived, and consent can be received orally or digitally, but must be recorded in the patient record. You can find those answers on the Division of Consumer Affairs Frequently Asked Questions page, and they'll help guide you a little bit more than just that. But again, it's always going to be a question of you knowing with whom you're speaking and then recording who it is. You may be asking for identification, some identification. I think the website talks about perhaps looking at a driver's license number to confirm someone's ID. But you do want to take consent, and it can be done orally under these circumstances.
Great. Ketamine again. Is ketamine being used for the treatment of PTSD? PTSD research is very focused now on more the effects of methylene dioxymethamphetamine, commonly known as ecstasy, and perhaps other hallucinogens. Ketamine is a dissociative anesthetic, and it is mostly used for the treatment of depression. Maybe it will have, through anxiolytic effects, some effect on PTSD, but most of the PTSD interest now has to do with the hallucinogens. Do you think that there will be, this is shifting, do you think that we'll be seeing an increase in ASD. ASD is
Acute stress disorder.
autism spectrum disorder, yes. There's PTSD secondary to COVID-19. And if we see an increase in autism, do you think the resolution of this will be in line with the resolution of COVID-19? I do expect some increase in PTSD, especially for people who are at the very center of the traumatic event, people who have lost family members from COVID-19, people who themselves may have been treated for COVID-19. As you know, it's a pretty tough disorder. We're going to be seeing perhaps with healthcare providers who are working closely with COVID-19. I'm not sure about autism spectrum disorder. I haven't seen any research on that. So I'm not sure how that will play out.
Petros, in some ways, I think we will also see a rise in, there's PTSD in patients who stay in ICUs, like there's a lot of literature on that. And with COVID-19, there is so many patients who get intubated, who get the level of ICU care. So we might expect high rates of PTSD in some of these patients. But I think one thing that we're not used to seeing that much, which we probably will start seeing, will also be PTSD in a lot of healthcare professionals, nurses, respiratory techs, EM physicians, people who have been sort of dealing with, like anywhere you read about or hear about their experiences, they all talk about that they've worked with Ebola patients, they've worked with crises before, but this is like nothing they have ever seen. So I think we will be seeing a lot of that in our own colleagues and ourselves too.
Absolutely. I'm just going to point out that, as I mentioned with a couple of psychiatric disorders before, some aspects of mental illness may actually get better under the pandemic. And one could possibly make an argument for autism spectrum disorder that could be one of those candidates where people may feel more, the sense of belonging in that context. Where do you see the greatest need after we return to our new normal? And I'm going to ask all panelists to take a stab at that. Where do you see the greatest need after we return to our new normal? I do see the financial loss and the economic devastation to really take a big toll on people as a society. So I'm not sure how we're going to address all that, but for the most economically depressed, for the most underprivileged sections of society, this may be very, very hard. Nancy, Clement, Rashi, if anybody else wants to have an idea here.
One side effect or benefit of COVID-19 also has been a little bit of a different trend of people speaking up a little bit more in the healthcare business or industry. And I think nation as a whole is also seeing how we have failed, like how the system has failed us and our patients and or not, and sort of also thinking a little bit more in terms of a wider, like all of us as healthcare providers today on the call, how has it worked out for you? And is there a role for you in future, whether it's by advocacy or just speaking up? It's also sort of almost like reimagining the system, and maybe that might be a little bit of a positive outcome. So that's not an immediate need, but that's something I think we will have to think about.
We have a few weeks to really put our heads together on this one, because we do have a session at the end about where do we go from here. So stay tuned and come back and visit us in 3 weeks. All right, in patients sensitive to benzos for their anxiety treatments, what's the thought of selecting Buspar as an alternative treatment option, especially in patients with previous treatment of brain arteriovenous malformations? Okay, I'm very glad you brought this up here, because benzodiazepines are particularly problematic in the context of COVID-19 because they do depress the respiratory system. And God forbid, if you get infected with COVID-19, you want to have your lungs working at their fullest capacity. And this being on benzodiazepines, using or abusing benzodiazepines and being fighting COVID-19 is particularly challenging. So using buspirone perhaps is a solid idea. We do use buspirone for the treatment of anxiety disorders, and I think that's a very good point. I'm not sure if there's anything specific about AVMs in this case. All right, watching news and briefings for information versus too much depressing news. Need to know versus TMI. How much do you watch? Excellent question. I was going to bring this controversy up, talking about the psychological first aid. One of the tenets of the psychological first aid is not to be involved too much with the media, not to get too much information. Solid research, and it keeps on coming up in disaster psychiatry, but I think it may be a little outdated. In 2020, when everything goes through those screens, either on the cell phone or on the laptop, and we get so much information, I'm not sure if we can really contain it. But I do have to say that research does point to the idea of constant reminders and exposure to the traumatic events as being a negative predictor of outcomes, of psychological outcomes on a social level. So I'm very glad you brought this up.
I just wanted to add, Petros, that as a parent of a teen, what I'm about to say, I know is not always going to be followed. But, news and information is healthy as you anticipate and plan for disasters. But this, like checking news all day long and having notifications on is not the best methodology. So checking news once or twice and restricting your time might be the best way to do it. And the best way to do that is to turn off notifications. If people you're giving advice to will follow that.
Yeah. I compare this country with Greece sometimes, where the TV will only show the most dramatic and the most extreme, pictures of bodies being dismantled and this and that. Well, at least in the United States, people are a little more contained with the graphics of these matters. We need to contain some of the gore of what we see.
And I also think there's a lot of channels these days showing the silver lining, focusing only on the silver lining of COVID-19. And, with all the good stories that are brought, I think focusing on that also can definitely help.
We get another one here saying, apologies, I should have specified ASD as acute stress disorder rather than autism spectrum disorder. I knew there was something a little difficult about that question, and why pick autism specifically? Anyway, acute stress disorder goes very much along the lines of PTSD, and we have addressed that. How would you deal with the internal employee relationships concerning the effects of COVID in terms of PTSD? Let me say that again. How would you deal with the internal employee relationships concerning the effects of COVID, parenthesis PTSD? I cannot wrap my head around this question.
Petros, is it about, like in some ways in your role as a chair, you're asking your employees to go in and face something that might be life-threatening? So how do you deal with that?
That's a tough one, because on one hand, that's a tough one in that.
Actually, I've observed you do this, so maybe I can still say what I've seen you do.
Okay.
You've been very open in communicating what is needed, being open in talking about what are the actual risks and what you can do to support us as we do this. So it's almost like, you can't protect everyone, and especially all of us in healthcare. We can't be protected from the risk, but knowing that our immediate boss and leader cares and is there to support me when I need something, I think it's that kind of an equation. At least that's what I have seen observing you, Petros.
Thank you, Rashi. I'll talk on the personal level here, that 3-4 weeks ago, when the social distancing mandate came out, my administrative assistant was there every day despite the fact that she had all access to the computer from home. My administrator was here, and I was screaming on top of my lungs, you should be working from home. You should not be coming in. Go home. And then I thought to myself, I need to lead by example somehow here, and I need to be working from home as well. So for a week and a half, I would come into the hospital only when I had to see patients, and I would try to do everything else from home. It was a miserable time, but I appreciate that it would be miserable for other people as well. But at the end, I felt that I needed to be here. I've been coming in every day. I do see some patients. I saw a number of patients yesterday. I'm not going to be seeing patients today, but I'm still at work. I think it's important to visit the psychiatric units that we have, the emergency room, the inpatient unit, the consultation service. I'm not sure how I'm going to judge my response after all this whole thing is over. But right now that I'm in the middle of it, I just don't see myself not coming physically to where my colleagues are battling the COVID-19 fight and working with the patients face to face. So that's what I decided to do. Again, we'll find out if there was a correct decision or not. All right, we're coming to an end here. So we'll have a couple of things I want to cover. Not a question, just want to let everyone know that Children's Mobile Response is still available for children, teenagers, and young adults for mental health services. The parent can call Perform Care at 877-652-7624. That's 877-652-7624 for Children's Mobile Response. And one final question before we close. As with other healthcare inequalities, mental health care has not been an option for many in underserved communities. Do you see this changing after the pandemic passes? I'm going to just say very briefly what Rashi Agrawal mentioned earlier, that one of the silver linings of this pandemic is that it's going to expose our inadequacy in terms of offering mental health services to our communities. And perhaps things may get better at the end of the pandemic, and people really seeing the need for these services and try to address some of these incredible healthcare disparities and inequalities that we're facing today. And with that, I'm going to close here. I'm going to read the final section here. As we approach the end of today's ECHO, we want to thank you for attending and participating. This session has been recorded and it will be made available on our New Jersey Project ECHO COVID-19 website. We would also like your feedback regarding your interest in participating in subsequent sessions of this subject. Please take a few moments to complete our post-session survey so that we can gauge our interest and plan for upcoming sessions. So our next session is next Friday at 12 noon. Dr. Clement Chen is going to be giving us the presentation on COVID-19 and substance use disorders.
Yes, and I think that last question is a good kind of like what we'll talk about, foreshadows what we'll talk about next week in terms of substance use and how the delivery of MAT, what we're doing now, and how that can be, really something we can use for the long term. So
great.
Thank you for the question too.
Excellent. Anybody else, any final comments or ideas? Or all right, hope to see you all next Friday. Have a great weekend, everyone. Bye-bye now.